So I'm going to give a brief update and uh, timeline on what we hope to be our EPSMS clinical trial for summer and fall of 2024, where we, after years of delay, mostly due to the COVID pandemic, will finally be able to get started on our EPSMS clinical trial. So next slide, please. Yeah, so a couple of sections here, brief review of multiple sclerosis, which I will breeze through because a number of our presenters today have already talked about MS and imaging demyelination or remyelination in MS. So next slide. Yeah, just a bit of history. People have been trying to learn more about this disease for, uh, frankly, uh, I guess we're almost approaching 2 centuries now, if we date from the original French neurologist, Charcot. But we've had several speakers today talk about the various forms of MS. The key notion here is that it is an autoimmune disease that involves both the immune system and the nervous system, and it impacts um, most concretely or explicitly, as far as what we can see with medical imaging, the myelin sheaths around the nerves in the peripheral nervous system, and the myelin in the central parts of the brain. Next slide, please. So, as we've heard in a number of different ways throughout our workshop today, historically, we never had imaging half a century ago, and then it was all about magnetic resonance imaging. But it has always been my hope and dream that we would be able to use molecular imaging with PET scans, because that's the only way to get at the underlying biology. That's the only way to get at the neural pathways. So it is my continued hope and dream that we will very soon be able to use molecular imaging with PET scans. And there has already been a good number of studies, especially coming out of Italy, and now also more recently Spain. So the Europeans are frankly way ahead of the Americans in using PET scans to image multiple sclerosis. We do have 3 FDA-approved radio tracers originally developed for the study of dementia and Alzheimer's disease, but by happenstance, they also bind to myelin. So next slide, please. This is, in my opinion, undoubtedly the most important single slide in this presentation, because it demonstrates in a very simple manner, a simple 2x2 table of what I consider the most important foundational concept for our EPSMS study, our clinical trial. And that's the difference whenever a tracer is used to try and identify the presence or absence of a disease. It can be used what's the target? What are we trying to detect? What question are we trying to answer? Are we answering a question about Alzheimer's disease, or are we answering a question about multiple sclerosis? And what we may consider presence or absence of disease, meaning what's the signal, and can we do that cleanly, neatly, correctly, accurately? Well, that depends on how much noise there is around the signal. So if the signal is buried in noise, then it becomes very difficult to understand whether it's a true positive or a false positive, whether it's a true negative or a false negative. So this slide is the most important foundational concept about our EPSMS study because they're kind of the opposites of each other. In Alzheimer's disease, these tracers that bind to both amyloid and to myelin, it's the gray matter where we're looking for target signal. And if and when there's binding in the white matter, that's considered off-target noise. Conversely, it's the exact opposite when we are using these tracers for multiple sclerosis. In this situation, it's the white matter where we consider it to be the target signal. But if we also get confusing binding in the gray matter, then we consider that the off-target noise. So it just depends on what question we're trying to answer. So this has consequences for how we establish policies for reporting, how we establish policies for inclusion or exclusion of participants in clinical trials, as well as what is often done in the profession when ordering scans involving radioactive materials, the so-called appropriate use criteria. How are we going to develop and clarify our appropriate use criteria when these radiopharmaceuticals as imaging agents can be used for both Alzheimer's disease and multiple sclerosis in this way? All right, next slide, please. Here's an example of one of these amyloid binding agents that comes from a colleague I've worked with, Chris Rowe at University of Melbourne in Australia. This is a normal subject where the dark coloring is the binding of the tracer to the white matter. So you see the central white matter in the brain, and then you see the white matter around the subcortical structures connecting down to the spinal cord. Next slide, please. So we have amazing new technology that's now available in just the past several years. One of the bright sides of the delay caused by the COVID pandemic is that we're now in a world where there are now several years of experience with these new scanners, such as the United Imaging Explorer PET-CT. The folks at Banff Health in Michigan now have a full 2 years of practical experience with their scanner there. So a lot of progress has been made, and these scanners are just extraordinary, truly remarkable for those of us who have actually seen how this progress has been achieved over the past several decades. It's just unimaginable when you compare a current state-of-the-art image from a United Imaging Explorer to what was available at the beginning of PET scanning back in the 1970s. So in half a century and approximately 5 decades, there's just been remarkable progress in this technology. That enables us to engage in our EPSMS study, where we want to not just look at the brain, but also look at the spinal cord. Next slide, please. So that's the key question here. We don't want to just look at the head and the brain. We want to look at the entire body, including the entire spinal column. So ideally, we'd like to be able to visualize the nervous system all the way down to the bottom of the pelvis, so that we can see the entire spinal cord and all the various peripheral nerve roots emanating from the spinal cord. We are using FDA-approved imaging agents, so we know that they're safe. Excuse me. And that eliminates a lot of the regulatory requirements when we are using FDA-approved agents in an off-label context. Nevertheless, we, of course, do go through full IRB approvals, both as central management IRB approvals as well as local site-specific IRB approvals, which will be done at each imaging site. And they've already been done at both UC San Diego and UC Davis. Next slide, please. Next slide. I guess it's my eyes. So this is just a review of the inclusion criteria, and I want to emphasize that last year we did an amendment where we dropped the EDSS criterion on the original protocol that was written up prior to the COVID pandemic. That was well before the production actual clinical use of these new scanners, and it was obviously before the COVID pandemic. And so in the intervening half dozen years, because the original protocol was written in 2018, there's been so much progress in so many aspects of healthcare that a lot of MS patients are doing much better, and it's become, there was concern that we would not have trial participants if we maintained the EDSS greater than 5 disability score for severe disability. So that criteria was removed in last year's amendment. And so now the only MS inclusion criterion is simply a diagnosis by a credentialed neurologist according to the revised McDonald criteria that was published in the Thompson et al. Article in 2018. Next slide, please. Again, here on exclusion criteria, I just like to highlight what was already mentioned earlier today. We want our participants to be able to also get MR scans and PET MR scans if and when possible. So no metal. The other one that I've already mentioned, no comorbidities prior to initial onset and diagnosis of MS. Next slide, please. So we are obviously, I've mentioned several times now that we were on hold during the COVID pandemic, but we are really hoping to get going this summer as soon as we get our 2024 amendment done and approved. We do have continuing support from Avid Radiopharmaceuticals. And the next slide we've already talked about the amendment that I'd like to address regarding which collection of questionnaires we're going to ask our participants to complete. But here are several other important amendments that I'd like to get in our protocol revision. We are very optimistic that GE Healthcare will support us with 20 doses of Vizamyl so that we'll be able to do 20 Vizamyl scans. and that Life Molecular Imaging will support us with 20 doses of Neuraseq, so that we will be able to really expand this exploratory pilot study up to actually a total of 60 scans if everything comes to fruition as discussed at the recent SNMI meeting in Toronto, where I met with folks from both GE Healthcare and from Life Molecular Imaging. Of course, the company behind Amyvid is Avid Radiopharmaceuticals, which is part of Lilly. So the other important amendment to the protocol that we'd like to make possible for those who wish to participate, we do have some sites. One in particular that is very motivated to assist and support our clinical trial is Banff Health in Grand Rapids, Michigan. They have a PET MR literally adjacent to a PET CT, and it's just seconds apart. If the participant is willing to lie in the gantry bed on the PET CT scanner, it'll only be 5 minutes on the PET CT scanner, it'll only be 15 minutes on the PET MR. That's how good these new brand new state-of-the-art scanners are. They're that fast and they're that good. And so for those participants who do wish to get both done, the major advantage here is that both scans can be done on a single dose of the radiopharmaceutical. So we're hoping to make this imaging protocol available at those sites that will offer it. Our anticipated partner sites include UC San Diego, UC Davis, WashU St. Louis, University Hospitals in Cleveland, and as mentioned, Banff Health in Grand Rapids, Michigan. And we are hoping to start later this summer. So that should be it on my slides. Next slide, please. I think I have, well, again, I mentioned this earlier in discussion before. We're focused on being able to monitor efficacy of therapeutic drugs and interventions to benefit individual patients and see what helps them the most. I think the last slide is the list of MS resources. Yes. So there will be a list of these MS support organizations. We do hope to make this, get this trial developed into a multi-site study, not just in America, but international, involving Australia, Japan, Europe, wherever partner sites want to join us in the future for an extended phase of this clinical trial over the next 10 to 15 years. So with that, I hope that everybody will join me with optimism and enthusiasm that we will be able to do our first scans later this summer. And if you have questions, please direct them to myself, direct them to Dr. Neidig, and we'll be happy to take your questions. So with that, if there's any further discussion, please.
Okay, so if I may,
please.
So of course the entire body PET scan will for imaging of the spine and peripheral nerves. Are you also hoping to be able to detect demyelination of the vagus nerve or other sort of organ-associated nerves?
Well, I think that's a very, very important and fascinating question, and I'm glad you asked. one of the really exciting things about doing entire body scans is that these machines are so amazing. Our spatial resolution, our time resolution. It'll be fascinating to evaluate what can we see, what can we not see. How much of the nervous system can we visualize? So I think that's a wonderful question, and I hope that you will take an interest in exploring it as soon as we get our initial scan data.
Certainly.
Great question. Other questions? Because as we've discussed, it'll be great to evaluate as best we can also what's going on with the autonomic nervous system. Absolutely. All right. Well, I'd like to thank everybody for their support, and we should thank all the MS families out there who help and support the MS community. So with that, we'll call it a day. All right. Thank you, everybody.
And thanks to all the presenters. You guys did a good job. This was wonderful.
Thank you all.
Thank
All right.
you.
Bye-bye.
All right. Take care.